So I'm surprised after that opportunity that 8 people didn't get up and walk out.
Yeah.
All right, so today's grand round, Amanda Smith, one of our third-year residents, is going to talk about food insecurity today. And I think this is clearly a good topic. It's something we're beginning to understand in greater detail and its impact on what we do, what we take care of families. So, Amanda, if you take over.
Thank you, Dr. Bocchini. Can everyone hear me okay? Do I need to adjust anything? Okay. All right. Like Dr. Bocchini said, I'm Amanda, one of the third-year residents. And I wanted to talk about food insecurity. I first became interested in this topic in August when I was on subspecialty rotation, and we started incorporating the advocacy portion. Food insecurity was one of the topics that we focused on. And I felt like before that I hadn't really heard much about it or didn't know much about it, so I wanted to delve into it a little bit further. I have no disclosures or financial interests or anything like that. My objectives today, we're going to define food insecurity and discuss its prevalence in the United States, examine the relationship between food insecurity and obesity, discuss the psychosocial and health implications of food insecurity, and explore areas of improvement in clinical practice. So I just wanted to start with a couple of definitions. According to the USDA definition, food security is defined as people having at all times physical, social, and economic access to sufficient, safe, and nutritious foods. I want to highlight nutritious food there, which meets their dietary needs and food preferences for an active and healthy lifestyle. And households are considered food secure when all members of the family have access to enough food at all times for an active and healthy life. Until recently, food insecurity was subdivided into food security without hunger and food security with hunger, but they've recently changed the definitions. So now you have low food security, where families report reduced quality, variety, or desirability of diet, but there's little or no indication of reduced food intake. So they're not having to limit their meals as much. And then very low food security, where families report significant disturbances in their food intake. This is just a little infographic. Sorry, I know it's hard to read. So high food security, obviously that's where the households have no problems obtaining the quantity and quality of food that they want. Marginal food security, I feel like is an area that's not looked at as much, and is an area where we could make some more impact. These are households that have anxiety at times about accessing adequate food, but the quality and variety and quantity are not substantially reduced. So they worry about having enough food, but they're not necessarily having to cut back on what they're buying or reducing their intake. And then we talked about low and very low food security already. So there are a couple of modules that the USDA uses to assess food insecurity. And of course, all of these are surveys, so we don't know if people are underreporting or overreporting. But they use the core food security module. It has 18 questions, and it assesses over the last 12 months if families worried whether food would run out, if they had to reduce their food intake, if their children had to reduce their food intake. And some of them are yes or no questions, and some of them are often, sometimes, or never true. And all 18 questions apply to households with children, whereas 10 of them apply to households without children. And then the household food security survey module is, I believe, what is used in the census whenever they screen for household food security. And there's similar questions in the last 12 months. Did you have enough of the type of food you want to eat? And again, they're stratified for you always had enough, sometimes didn't have enough or often didn't have enough to eat. And a lot of the studies that we're going to look at used these two food security modules to determine food insecurity. Sorry. Okay. So now that we've gone over a few definitions, just wanted to touch on the prevalence. And this is an infographic from the AAP toolkit for addressing food insecurity. It says that 1 in 6 children in the U.S. Live in a food insecure household. Most of the numbers I found were between 1 in 6 and 1 in 8 children. And one thing I thought was interesting, in August when I was on subspecialty and we were talking about food insecurity, we took a vacation to Yellowstone, and particularly in Wyoming, I saw a lot of billboards with this type of information on it, which I thought was interesting because here we have a lot of syphilis billboards, but I haven't seen too many food insecurity billboards. According to the Children's Health Fund, which is one of the resources we use on the subspecialty rotation, this is all 2015 data. 13% of U.S. households were food insecure. 5% had very low food security, and 17% of households with children experienced food insecurity at some point during the year. Of that 17%, 9% were adults only, and 8% were adults and children. And it was more prevalent in low-income households, ethnic minorities, and female-headed households. And the next slide's going to elaborate on that. So the national rate was 8% of children experiencing food insecurity. And it was higher in ethnic minorities, higher in Hispanics than blacks. Of course, income to poverty ratio plays a large role. And then the single female-headed households were higher than both the ethnic minorities. So I thought that was interesting as well. This is another source, Hunger and Health, Feeding America. It's a really cool website if you want to check it out. This had 2017 data that showed that 1 in 8 Americans are food insecure, which comes to about 40 million Americans and about 12 million children. And they had this, sorry, I know this, a lot of this stuff is kind of blurry, but they had this cool interactive map with food insecurity rates. And you can see the dark green is greater than or equal to 30%. And right here, Mississippi, Arkansas, Louisiana is a hot spot. And on this map, you could search by state or county or parish. And like we said, 48 million people in the U.S. are food insecure, which is about 15%, and 54% are below the 130% poverty level nationally. So then if we look specifically at Louisiana, again, here are some that are hitting 30%. For Louisiana, there were about 800,000 food insecure people, which makes about 17%. And remember, the national rate was 15%, so that's higher than the national rate, with 57% below the 130% poverty level, and the national rate was 54%. Child food insecurity in Louisiana as a whole is at 23%, which is about 260,000 children. And then I've highlighted Cato Parish. There are 51,000 approximately food insecure people in Cato Parish, which gives us a 20% food insecurity rate, and 55% are below the 130% poverty level, which is a little bit better than Louisiana as a whole, but still worse than the national average. And child food insecurity is at 24%, which is about 15,000 children. So that's higher than both national and Louisiana average. And I also just wanted to briefly mention food deserts here. National Geographic has done a few pieces recently about food deserts, which are areas where there's no access to healthy foods, so no supermarkets or that type of thing within about half a mile of people living in poverty where they don't have access to transportation. And there may be fast food restaurants or areas or establishments like that where they could get food, but those areas don't always accept like SNAP vouchers or which used to be food stamps is called SNAP now. And one of those areas is actually in Houston. So I didn't dedicate a slide to that, but just wanted to mention those areas as well. Okay, so wanted to use this picture to segue into talking about food insecurity and obesity. So you can spend $3 to get a little bit of healthy food or a whole lot of unhealthy food, which has been postulated as one of the reasons for the food, what's called the food insecurity and obesity paradox. Of course, this is a very broad topic. There were a ton of studies on this, so it could be a grand rounds in and of itself. I won't be able to touch on all of them, but wanted to talk about a few in particular. So, like we said, there's been this nomenclature of the food insecurity and obesity paradox where they've noticed that children in low-income households that are more likely to be food insecure are also more likely to be obese or overweight. And we talked about some of the food behaviors, consuming high energy density but nutritionally poor foods, like the ramen and the sodas and all that from the picture before. And there was actually a study a few years ago where they looked at feeding practices among urban black families that were low income and thought to be food insecure. And they looked at 5 food practices in particular: the pressuring children to eat, restricting access to foods, using nutritional supplements, appetite stimulants, and adding sugar to beverages. And these 2 food practices, pressuring a child to eat and restricting access to foods, were defined by the child feeding questionnaire. So that was a questionnaire that they gave the parents. And then these 3 were derived from clinical experience. And they interviewed a convenient sample of black families of children aged 2 to 13. And they found that mothers in food insecure households were much more likely to use high energy boosters like Pediatric, Malta, Carnation, Boost, and that they were more likely to use a perceived appetite stimulant like cyproheptadine or vitamins or bush teas. So those could be some food practices that contribute to obesity as well. So this was a study using the National Health and Nutrition Exam Survey data. This was from 2015, and it looked at NHANES surveys from 2001 to 2010. They interviewed parents and children less than 18 years old to determine food security status, both at a child level, which means the household level, and a personal level. And obesity was defined as BMI greater than 95th percentile for age. So to determine household food security status, they interviewed them in the home, and then they took the children to a mobile clinic and did their weights and anthropomorphic data there and did further interviews. And they used the food security and survey module that we showed earlier. So the child level or house level food insecurity was an affirmative response to 2 out of 8 of the child specific items. And they further divided that into the marginal food security, low and very low. And then if they answered affirmatively to one of those, they also interviewed the child personally and asked 5 additional questions. And if they answered yes to one of those questions, then they were determined to have personal food insecurity. So what they found was the prevalence of obesity was higher among food insecure children overall, and then subgroup comparisons showed higher rates among food insecure compared to food secure counterparts. And in the overall model, again, they found that it was significantly higher among 2 to 5-year-old children with child level food insecurity, which was the household level, not the personal level. However, when they did further multivariate analyses, they saw no significant difference for the 2 to 5-year group at either the child level or the personal level. But they did see a significant association with obesity for 6 to 11-year-olds with personal food insecurity. And this is, sorry again, I know it's kind of hard to read, but this is the questions that they asked to determine child level food security. And again, it assesses in the last 12 months, did they have to cut back on food or that type of thing. And then the personal food security asked over the last 30 days, did they cut the size of their meals or eat less than they felt that they needed, or skip meals because the family didn't have enough food, those types of things. Okay. And this study was a longitudinal study looking at obesity in preschool children. This was a 2012 study that focused on low-income children participating in WIC programs in Massachusetts. And again, they used BMI greater than the 95th percentile for age to define obesity. They ended up having a sample size of 28,000 children, which is a pretty good sample. The children had to have both an infancy visit and a child visit. And at the infancy visit, 25% lived in households with some food insecurity. And again, this is an older study, so it still used the food insecurity with hunger. About 6% of them had food insecurity with hunger. And then at the child visit, 23% lived in a household with food insecurity and 5% with hunger. 17% of those children overall were obese. And for WIC, they had to have a poverty level less than 185%. And they found that infants from households with food insecurity without hunger had a higher mean BMI for age than those with hunger, which we would expect. And then there was a significant interaction between infancy household food security status and maternal pre-pregnancy weight status. So there have been several studies that have shown that food insecurity is associated with obesity in women in particular. So women who were overweight pre-pregnancy were more had a higher association with infants in a food insecure household. And then persistent household food insecurity without hunger was associated with 22% greater odds of obesity. Protective factors were Asian origin, mother with greater than 12 years of education, and an underweight mother. Okay, and then here's a study that showed food insecurity is not associated with childhood obesity, using multiple measures of obesity. So this was from 2007, and they used BMI, waist circumference, tricep skin fold, trunk fat mass, and body fat percent. and they used, again, greater than 95th percentile for BMI, waist circumference greater than the 90th percentile, tricep skin fold greater than 95th percentile. Trunk fat mass was determined by a DEXA scan of the T and L spine, left and right ribs, and pelvis. And they used the reference values for age and sex to determine obesity for those. And body fat percent was greater than 95th or 95 percentile, determined by a whole body DEXA scan. And they used greater than the 200th percentile for the poverty line, looked at obese versus non-obese, and found that food insecure children were more likely to be obese compared to the food secure counterparts across all indicators of obesity. But they did find that food insecurity and overweight status coexist in low-income children. So out of the children in poverty, 12 to 57% of them were of the food insecure children were obese, but it was not significantly different from food secure status. So from these studies, we can see that there are a lot of mixed results on food insecurity and obesity. Some of the postulates as to why we always measure food insecurity at the household level and not at the personal level. So if the parents are skipping meals or the older children are skipping meals, the younger children could be protected. They could be shunting food resources to the younger children, which could be contributing to their obesity. All right. So now that we've talked a little bit about the relationship with obesity, I wanted to talk about some of the health outcomes. Studies have shown that children that are food insecure are more likely to have developmental impairments, have more medical diagnoses, and be hospitalized more often, and also face higher risks of health conditions such as asthma and anemia. And one study found that food insecure children had a 90% greater odds ratio of having fair to poor health per parent report, 31% odds ratio of being hospitalized since birth, and a 76% greater odds ratio of being at increased developmental risk. This was a 2015 literature review, but not a meta-analysis, because again, there are a lot of studies out there that have looked at this, and it's nearly impossible to include everything. But the study broke groups down into children, non-seniors, adults, and seniors, and found that they're more likely to have birth defects, anemia, lower nutrient intakes, cognitive problems, aggression and anxiety, hospitalizations and poor general health, asthma, behavioral problems, depression and suicidal ideation, and worse oral health compared to food secure households. And this was a study published in Pediatrics that looked at associations with infant and toddler development. And they found that 18% of children food insecure households were at developmental risk compared to 13% in food secure households. And multivariate analysis revealed that they were more likely to experience developmental risk if they were older children, male children, low birth weight, underweight, or had a history of hospitalizations. And the interesting thing about this study, the results were nearly identical when they removed food insecurity with hunger, which would be the very low food security. So that implies that we see these developmental outcomes at even marginal and low food insecurity status, and not just at the very low food insecurity status. And they postulated a couple of different pathways for these developmental impairments. course, you have the nutritive pathway where, because they're not getting as much to eat or food insecure, they have more micronutrient deficiencies that could lead to neurodevelopmental impairment. And then the non-nutritive pathway, where food insecure households studies have shown that caregivers are more at risk for depression. And then again, food insecure households are more likely to be at the poverty level. So if you have a parent who's depressed, they can't function for themselves, much less spend time with a child to help with their development. And then if they're in extreme poverty and having trouble finding money to buy food, then they're not going to have as much money for toys and books and educational materials for their children. Okay. And this was a study examining the relationship between food security status and anemia risk at 18 months of age. And again, this is a 2015 study that was looked at children in Massachusetts who participated in WIC. And this was a longitudinal design using data from 2001 to 2009. In order for infants to be included, they had to be full term, not low birth weight. They had to be enrolled in WIC until at least 15 months of age. And mothers had to be enrolled in WIC while pregnant or postpartum, and who were not anemic. So once they excluded everyone, the sample was about 18,000 infants who were not anemic at 12 months of age. 20% lived in food insecure households in the prior 12 months. And that was further divided into about 5% were in very low food security status. And about 12% of those children who were not anemic at 12 months of age became anemic by 18 months of age. And interestingly, they found that very low food security was not associated with increased risk of anemia. And that was believed to be because these children were identified early and given additional resources to help keep them from becoming anemic. Another thing I thought was interesting, the Massachusetts WIC assesses for food security every 6 months. And they've done that since they were implemented in 1999. And I don't know if our WIC assesses for food security status in families. Okay. And this was just the graph showing that low food security was significantly associated with anemia at 18 months of age, as were minorities, non-Hispanic blacks, non-Hispanic whites, and then Asians were all at increased risk. Lower educational status of the mother was associated with increased risk. And then I did want to point out that breastfeeding duration did not have a significant impact on anemia at 18 months of age for the food insecure households. This is just a little bit more information from Children's Health Fund about the relationship between food insecurity and iron deficiency anemia. It's among the most common nutritional deficiencies in U.S. children. Occurs in about 9% of children aged 12 to 35 months. There are higher rates among WIC program participants at 11%, and then Mexican American children at 14%. And then it did point out that black children have higher rates of anemia, not specifically iron deficiency anemia. So more like the sickle cell and thalassemias and those types of things. And it does have long-lasting detrimental effects on neurodevelopment. And they found that school-age children with iron deficiency anemia had greater than 2 times the odds of scoring below the national average in math compared to children who were not anemic. So just, say obviously it's very important to make sure we identify these children early, and of course we do the 1 year and the 2 year anemia test. But this previous study showed that if they were not anemic at 12 months, that they became anemic by 18 months. So we're missing, up to 6 months, or about 6 months, if we identify them at 2 years of age. Okay. And then just wanted to touch a little bit on the psychosocial outcomes. So studies have shown, this was an older study, it was from 1998, but it showed that children in food insecure households were more likely to repeat a grade in elementary school and have more social and behavioral problems. And they found positive associations with aggression, anxiety, and irritability in children that lived in food insecure households. Okay, and this was a 2008 study looking at non-cognitive performance at school. Bless you. So they had a sample size of 4,700 children, and they used questionnaires that they gave to teachers in the spring of the 1st grade, 3rd grade, and 5th grade for the children. The non-cognitive skills that they looked at were interpersonal relationships, so how well they got along with other children, accepted children who were different, expressed their feelings in positive ways, and showed sensitivity to feelings of others. They looked at self-control. Which was the ability to respect others' property, control their temper, accepting ideas for the group. They looked at approaches to learning, which assess their ability to demonstrate skills such as attentiveness, task persistence, eagerness to learn, organization, and then externalizing problem behaviors, which was behaving in ways that interfered with the learning process, arguing, fighting, those types of things. And they used the USDA questionnaire to assess household food security status. And they overall concluded that food insecurity impaired development in 3 of the 4 non-cognitive domains: interpersonal relations, self-control, and approaches to learning. But they did not find significant contribution to externalizing problem behaviors. And then I felt like the takeaway from this study was that children who were food insecure in the 1st grade that became food secure by the 3rd grade had persisting non-cognitive impairments into the 5th grade. So the earlier that they're affected, the longer lasting the cognitive impairments seem, or the behavioral impairments seem to be. Okay. So we've looked a lot at younger children, and this was a study looking at the mental health problems among adolescents in food insecure households. And this was a 2014 cross-sectional study that looked at children from the early child longitudinal study, kindergarten, class of 1998 and 1999, who responded to the 8th grade parent interview. And they asked the parents how they felt their child's mental health was at that time, and it was mental health was assessed using the Strengths and Difficulties questionnaire. 10.2% of adolescents were in food insecure households, and 11.2% were reported by parents to have mental health problems. So they found that food insecurity was associated with a greater than 2-fold increase in mental health problems. Specifically, they were at increased risk for emotional problems. You can see that's quite a bit larger than the food secure bar. Conduct problems, which is this one, and peer problems, which is this one. So adolescents are also affected by food insecurity, and not just younger children. All right. So now that we know all of this information saying that food insecurity may or may not contribute to obesity, definitely has a large impact on neurodevelopmental outcomes, how can we improve our clinical practice? So one thing I thought we could screen at prenatal visits, since studies have shown that pre-pregnancy weight is associated with infants being in food insecure households, and then screen in the nursery and NICU so that we can identify these babies early and hopefully have positive outcomes on their neurodevelopment. Of course, screen all clinic patients, which we are not currently doing. I'm going to talk a little bit more about the 2-item screen from the AAP. It's just 2 questions that are very quick to answer. Could possibly start including these in our continuity templates, or even incorporate it into the Adolescent and Preventative Health tab in EPIC, where Ms. Tracy does the lead screening and the dental screening and those types of things. Okay. So this was the study that looked at developing the 2-item screen for food insecurity, and this was from 2010. This was a study that was performed across the country in Baltimore, Boston, Little Rock, Los Angeles, Minneapolis, Philadelphia, and Washington, D.C. And they performed interviews in hospitals and primary care clinics. They did not include children that were acutely ill or had injuries. And they interviewed caregivers of children less than 36 months of age, and approached only uninsured or people receiving public insurance. And they ended up having about 31,000 interviews. They wanted their screen to be based off of the Household Food Security Survey module that the USDA uses. So they found that most people who were insecure answered affirmatively to questions number 1 and 2. So they then did further analyses to determine if they answered question 1 if they were food insecure, if they answered question 2, questions 1 and 2, or questions 1 and or 2. So they looked at the 4 different answers, and they wanted it to be applicable to families with young children. They wanted it to be short and greater than 90% sensitive, greater than 80% specific, and they wanted it to have convergent validity. And they found that answering yes to questions 1 and or 2 was the most sensitive and specific. And so these are the questions that the AAP recommends, and they call it the hunger vital sign to screen for food insecurity. So within the past 12 months, we worried whether our food would run out before we got money to buy more. And then often true, sometimes true, never true, or don't know. And then number 2, within the past 12 months, the food we bought just didn't last and we didn't have money to get more. And again, you have the stratified answers, not just a yes or no answer. And this was answering yes to either of these questions was 97% sensitive and 83% specific at identifying food insecure families. Some of the resources that I found in our area, I couldn't find the 2018 list, but in 2017 there were 14 schools that participated in the summer food program, and that was listed on the Cato School Board website. And then as of August of last year, all schools are participating in no-cost breakfast and lunch, all schools that include an elementary or middle school. So it doesn't include standalone high schools. But if the high school includes a middle school, then all kids, regardless of poverty status or financial status, are eligible for no-cost breakfast and lunch. And then some of the food pantries, this is kind of an older list that I found, but the food pantries we have, Common Ground was a big one, and the star means that they have a clothing closet as well, where families can get clothes. Food Bank of Northwest Louisiana, a lot of them are churches. And then, so there's a lot of them. The Salvation Army, of course, has a thrift store where families can use tickets or money or something to buy, to get clothes and that type of thing. The Cato Council on Aging is for elderly individuals, but still a resource we should be aware of if we have food insecure families living with grandparents or that type of thing. So as you can see, there are about 15 or so places that are participating in food pantries. And then I just wanted to end with a video this is from the Hunger and Health website. They have a lot of little short 2-minute videos about people affected by food insecurity. And this one's about a child.
I daydream about my future a lot. I swear on my life, my kids will have a better childhood than I do.
The kids that come to the library are wonderful. They are often facing really difficult situations. I'm the teen librarian.
I get approximately 5 hours a day at the library. It's great. There's positive people, there's books, there's also computers we can play games on. My name is Emily. I live in a family with my dad, my sister, and my brother. My dad's a hard worker, but sometimes it's just not enough. We don't have a lot of food. My dad might buy food here and there, but it runs out really fast.
A lot of kids out here, their parents work multiple jobs, so they're really pretty much on their own from the time school gets out until late at night. We realized that we had to do more. So from there, we were able to add in the snack time. Snack time is a program that everyone ages 0 to 18 is able to come into every day at the library.
The snack time is amazing. It's really healthy and it's really yummy to eat. I usually get my food from school and the library.
It really helps with their behavior and it really helps them do their homework.
I think eating food makes me feel a lot better so I can focus more. If I didn't have any of that, then my family would probably starve.
For a lot of our kids, it's a really important part of their day, and it is for us too. When they look at you and you know that you're helping them, it's impossible not to love them.
The reason why I get out of bed every morning is because I have friends and family that keep me positive, and because it's library.
Okay. So, thought that was a neat program that they had wherever she was from, that they had somewhere to get at least some sort of food for dinner, since they can only get breakfast and lunch at school. You know, she may not be getting dinner every night if it weren't for that program. And that is all I have. So if anyone has any questions.
So, I don't know if this came up or not, but with like technology being so much better and a lot of these like primary jobs that people used to do that robotics are going to be doing and stuff, like ice cream dispensaries and stuff like that, did you find or see anything that is showing that there's more like, higher concern of more food insecurity is going to happen because parents are not going to, some people that were using these jobs to, work from home are not going to have these opportunities anymore? Is there any kind of thing that has any kind of correlation with that?
I didn't come across anything in particular about future food insecurity rising. Of course, with recessions and decreased employment, food insecurity tends to rise in those times. But I did find that a lot of, or at least the food desert articles say that poverty doesn't look like it used to. A lot of families that live in poverty still have jobs and have cars and, have access to a lot more things. They're just not making enough money.
One of the areas where we're seeing a lot more food insecurity is in our immigrant population, partly because they're more hesitant to access public services that are available. So that's something to be particularly aware of in the clinic. Recent immigrants, but also folks who've been here 10 or 12 years are more nervous about accessing public services.
Yes, sir.
So my explanation, thank you. So we are doing in our 65 versus we are doing a quality improvement project on research. The 2-item questionnaire we are going to see of patients and families, and we're more and more identifying that there are patients and families who doesn't have food needs that sometimes every day, and when we actually look into it, we see that problem so we were able to work with our social worker. And many of our patients are from far away places, not from Shreveport, so it's difficult for us. So our social work is working with, collaborating with local agencies to help them find the resources. But we have to still analyze the data, but we are finding a lot of families because food is important to everybody, but for the patient they need to see it, it's more important.
Anything with like your adolescents, is there any social stigma that they're experiencing for participating in school breakfast or school lunch, like that maybe is compounding in food insecurity?
There were some that did mention that they don't necessarily eat lunch at school because they don't want to be associated with the poverty. And then some of them just don't like the food at school, so even if they have it available, they won't eat it.
But for Caddo Parish, no matter what socioeconomic level they fall into, it's free. It's free for everybody. Breakfast, lunch, nobody pays for any of it as far as the students. So anybody can go through the line, which has been terrific.
Did you find any, I know you mentioned that there's kind of a correlation between like food being cheap and food being unhealthy. Did you happen to find any resources that we can give our patients? Because a lot of times we recommend healthy diets, and fiber, and vegetables, and nutrition, but it's just not affordable. Did you come across any resources where they just said where they had maybe meal plans or like grocery lists where you could be where it would be more affordable to buy certain things that are nutritious? Because sometimes I feel like I'm like, here, eat all this healthy food, but also I know you can't afford it, so
Right.
I'm just making you feel bad about it.
No, I didn't find anything like that aside from the list of the food pantries. But there was an article on the Hunger and Health website where a residency group in North Carolina they did a QI project and have started giving scripts for healthy food, and they've partnered with like Lyons Grocers or something where patients can take those scripts and use them to buy food or to get food at specific food pantries and grocery stores. So nothing here. Dr. Bianchi?
Some of the Caddo Parish branches of the libraries, not all of them, but some of them are doing this after-school snack stuff and activities and stuff in some of the lower-income neighborhoods. And if you weren't aware of that, that is a resource, and you can call and check for some of your families where they're living and see if their local library is doing that. And then also locally, the local public radio station is a couple times a year now is having drives, for lack of a better term, where they're having backpacks full of food that they're providing for kids over extended holiday absences, like they did one again just recently before Christmas and stuff, where they will they've paired with some big corporations to fill these backpacks with food, and then the backpacks are given to kids to tide them over the times when the schools are not open, where they can't get their breakfasts and lunches at school. So that's something in our community, and probably is going on elsewhere around the country too.
Motion Parish has a backpack program on Fridays. They bring those to get kids through the week. You know, the
Yeah. And I think Caddo does too for some kids, but this is more community-wide with the public radio station stuff. So.
Dr. Thompson?
Some communities, they partner with the Ag Center and have community gardens. So they teach, especially in MLK here, they have a community garden, so they teach people in the community how to grow food so they can be more self-sufficient, and then they can come to the garden and get healthy food to take home and cook. So they try to make it a community effort. So they do that. And then in like the backpack program, they'll pack food on Fridays, and it's for the entire family until Monday. So they'll have like non-perishable items. And you can go to the food bank. One of my organizations, we do a food drive every year in January around MLK. And they have a form to fill out. Like if the Peach residents wanted to do a food drive, they can come and collect the food, and they have how many barrels that you need to put like non-perishable food items in, and then you can take them to the food bank. You can help pack food bags for families that come, and a lot of churches do food distribution. My church does the food distribution once a month. But if you go through the food bank, because interesting about the food bank is they buy surplus food. They also take donations in, and then they are actually the hub for the food banks in the smaller communities. So our food bank is a very big part of extending out into the smaller parishes and places that don't have food banks. So it's really good if you do a food drive to speak with them, because they really service a very large community.
I guess I had a couple questions. The questionnaire, the two-question questionnaire, is it designed for the provider to ask the question to the parent, or is it given to the parent for them to answer?
I think both work, but I think it was originally designed to be one of the questionnaires handed out on intake that they answer ahead of time.
Okay. And then you indicated that we're trying to get that into EPIC so that it could be answered, or the answer could be permanently within EPIC, or?
I just thought that would be one of the ways that we could be sure to screen our patients.
Okay. And then, are we doing that yet, or are we going to do that soon, or?
I think that's something we can definitely incorporate, at least as a handout. We're already doing kind of depression screening. So if we add along that, so the mom or the family when they come in for their initial visit, give them time to discuss it, think about it, and then creating a handout of the resources. So if we do screen positive, whether we do have something to help offer, not just saying, okay, well, we have food insecurity or food shortages, but we don't really have food.
Yeah, so that was my next question, was are we going to update the resources and then have them available so that we can then direct somebody to the right place for them? Okay, all right.
Well, and the other thing with the meeting we have with Laurel, that step forward is creating a website with resources. So once that's up and running, which is supposed to be this summer, we ought to be able to put that link into our resources in Epic, and so that you can just go directly there and see what's available for a variety of different issues, not just food that'll be included.
Although we haven't been doing any of the food insecurity questionnaires with our moms in the nurseries, one of the things we've been doing the last couple of years is screening and looking for the moms that look like they have iron deficiency anemia, whether OB has classified them as that such or not. And then in our recommendations, we're putting to check ferritin levels on those babies at about a month of age to see if they are low, to start them on supplemental iron and stuff to hopefully keep some of this later anemia from occurring. You know, because like you said, generally they're not going to be checked until they're a year old. So by then, it may be a little late to undo some of you've passed some of the critical window in terms of brain development and stuff. So we've been looking at that. Not specifically the questionnaires about food insecurity.
All right, no other questions or comments? Thank you, man, that was very nice, very nice.